As a background, the St. Michael's virtual echo round has been around for about 4 years. Actually, it's a product of COVID. Like everything else good, and sometimes it comes from very difficult situations where we have to innovate. And during this time, we actually convert everything to virtual, and subsequently, after 2 years, we realized some of the work that our colleagues actually put together is actually so good that's worth listening to. And then it took some moments to convince our colleague to be brave enough to actually post it onto the internet for being perpetual materials. And as many of you know by now, it becomes very useful resources, especially when you are getting the new field, whether you are a cardiology resident new to the field or sonographers new to the field. And there are useful reviews on very basic topics, but also there's very advanced topics. There is a subscription to a newsletter or weekly letter that sort of foretells what is the seminars coming up on Thursday. This meeting is actually running typically on from 8 to 9 a.m. Eastern Standard Time, because there are many people actually come from different time zones as well across the country. And you can join live via Zoom, and then it will be archived, and typically we'll release the recorded session sometime over the weekend. So for people who could not make it on Thursday morning from 8 to 9, then they can actually review it. And this has been used by many sonographers as well as other practitioners who are busy, scanning in the morning and scanning in the morning, so they couldn't actually participate in real time. So still become very useful resources. I've heard lots of interesting story about people like, doing their grocery and listening to our talks on a Saturday and Sunday. So please continue with that activity, and so on and so forth. So right now, our YouTube has about 3,500 plus people who have signed up and followed. Also, our newsletter is about 500 people strong. So we do have people actually joining from many different places, including many of our former fellows who have led their labs in Saudi Arabia and all across Ontario. So without further ado, with that introduction, I'm going to share with you my topic today. So the title is Bubble Bubbles Solve My Troubles. So anyone knows where this may be paraphrasing from?
Yes, the contrast bubbles that we use.
Okay, well, I'm going to talk about contrast bubbles, but or it could be agitated setting bubble. Where is the quote from, or paraphrasing?
No idea.
It's Shakespeare.
Yeah, it's Shakespeare Macbeth. So here it is. So it's one of the actually most commonly misquoted quotes. The original, many people have actually wrongly said, including myself for many years, bubble, bubble, toy and trouble, fire, burn, quadrant, bubble. But in fact, it should be actually double, double, toy and trouble, etc., etc. But be that as it may, it's certainly caught a few people's attention when this announcement went out this week. So I'm going to talk about microbubbles and contrast echocardiography, some of the basic physics, and also in the second part of my presentation, I'm going to talk about some of the interesting cases. Anyone know what I'm actually demonstrating here? It's one of the experiments I got myself involved in during my training in year of 2000, actually, many months ago. It's actually perfusion imaging. So actually, that's one of the expertise that Dr. Howard Leon Poy, one of my dear colleagues, actually specialized in. So in particular, I'm going to talk about some of the very basic physics that you may or may not have heard of at this point, which is contrast harmonic imaging, and how this is actually all factored into the bubble ultrasound physics. We're going to talk about how it is generated, why microbubbles important, and what are the characteristics, what are current clinical applications, and where we go from here as well, where we have been going in the last 20 years for bubbles. So first of all, harmonic. So from the dictionary, it's the theory or study of physical properties and characteristics of musical sound. So it's a tone in the harmonic series of overtones produced by a fundamental note. So you have a C, and then, a number of keys after. Then you have another C, which is another octave. So many of you play musical instruments, so you know about this, and so on and so forth. And a wave is when the frequency is a whole number, multiples of that of another. So this is actually harmonics. So typically, when we actually have an ultrasound, when we insonate, so we produce the ultrasound, and it's called the fundamental frequency. So typically, it will be concentrated in what we call the F, which is the fundamental frequency. And the classical theory says when you send off a fundamental frequency, what you should be receiving is something that actually surrounding that particular fundamental frequency, and that no new frequency is generated. So that's the classic theory. However, that's not the case, because when tissues get insonated, they also vibrate. So they're like, you're tapping a bubble or, a tissue, then it actually reflected a whole bunch of frequency back, and also they surround many, many different octaves or multiples of that fundamental frequency. So, but typically there's a second harmonic, and then there's a third harmonic, so on and so forth. But the second harmonic is much stronger than the third and fourth, so on and so forth. So indeed, but then again, when you actually insonate the bubbles, because they're not as fixed as the tissue, so they start vibrating. So just like when you tap a softball, a beach ball, for example, it actually start vibrating in multiple frequencies. So this is the tissue harmonics that we used. Nowadays, almost all echo imaging is done by using second harmonics tissue imaging. There's another set of lectures that I can use and talk about how it reduces near field artifacts as well as all the fuzziness around, because when you just focus listening to tissue harmonics, we get rid of a lot of the side lobes. But what today I'm going to talk about is actually the physics behind the contrast harmonics. Is when you insonate at the fundamental frequency, and let's say you tap the bubble or the beach ball, it starts vibrating with multiple bands of frequency, but still you have amplification at the multiples of the frequencies. So again, you get like F, 2Fs, 3Fs, etc., etc. And you can imagine if you just concentrate looking at 2Fs, then you can have improved in the signal properties as well. So the amplitude and so on and so forth, and you get rid of a lot of the side lobes, etc. And typically nowadays, all the echo machines is actually doing the 2Fs listening. So again, the harmonics is multiples of fundamental frequency, and we talk about how contrast harmonics actually generated. So what are microbubbles? So this is actually something that we often struggled to find a very easy way to explain to our patients, because this is the verbal consent that we do every single day. Is basically one way to say it to our patients is gas enclosed by a shell, and that's the fundamental sort of concept. And then in the next slide, I'll show you multiple versions of it. It's a different shell with a different gas. So you have multiple combinations of them. The reason why microbubbles work is because they are very strong scatterers of sound, and there's a large difference in the acoustic impedance between the entrapped gas and blood. Similar to the concept of agitated saline contrast, when you inject agitated saline contrast, you see it's really bright when it shows up. It's because when the ultrasound hits the boundary of the bubble, a lot of it gets reflected off. This is actually one of the very first paper on how bubbles are generated. The original paper was circa around 1989 by Dr. Feinstein, and this is actually how bubbles was initially made. In fact, one of our colleagues, Dr. Robinson, is one of our pioneers in this area, and he would have this in our office. And I think up until very recent time, we still have it in our office. And it's basically you have a insonator that actually vibrates, and you can put it into a volume of fluid. Initially, it was actually albumin. So our colleagues would actually go down to the blood lab and experiment on expired albumin. Obviously, we wouldn't give it to other people, but you can actually use it for doing experiments and so on and so forth. But as you can see, blood product is a problem because there's infectious risk, there's expiration issues, so on and so forth. And then later on, it becomes casein, which is cow's milk. So one of the very original bubble was actually made by cow-derived milk. And there's another problem. Do you know why cow's milk is a problem? In the 1990s. Maybe you're too young to remember that. So unfortunately or fortunately, I was actually at the time in UK, and there was a concept called mad cow's disease that you may have learned in medical school or in your health school. It's a prion disease. So using animal-derived sort of milk product is not a good idea for the shell either. So then, things actually kept evolving. The initial paper basically showed by using this installation method, you can produce bubbles of various size and sort of concentrating around basically about 3 to 4 microns. This is how wide or the diameter of the bubbles that could be generated by the method that I just shown you. So the idea is that the signal strength is proportional to the bubble radius. So the larger the bubble, the more reflection. So that's why when we give agitated staining contrast, it's typically around 60 to 120 micron, which is a lot bigger than the microbubbles that we give. So it's actually much brighter. But those bubbles, when we do agitated staining contrast, or the new device that we're having, which is like a one-shot thing, you don't have to agitate, you can give it by yourself. It creates bubbles which are larger size, and they get filtered by the pulmonary capillaries. So we actually do studies, you see that all the bubbles get stuck up there. But when you do studies with these bubbles, which are typically around 1 micron, you can see that they're like shoulders lining up to go across a narrow tunnel. So you see like each bubble actually lining up at the capillary levels, and then they can traverse to the other side. That's why you see the echo contrast showing up on the other side, but not agitated staining contrast unless you have some kind of intracardiac shunts. Okay, so this is actually a very old list of the contrast agent that has ever sort of showed up in history. So look at the first one, was very interesting. I think both Dr. Leon and myself was using these when we were young. So including Alphanex, which is a sonicated human serum algorithm. Okay, then we were starting to use something called Livovis, which is galactose microparticles. And during my training early on in my life, we're using something called Optizone. But see that you're still using a human serum albumin and sonicated 1% per fluoropropane. And so now it's like introducing a noble gas. The reason why we're using noble gas is because high molecular weight, so they diffuse out slower. So you must have all experience with having this balloon that you had when you were young in your birthday party. So initially they are like rubber balloons, and then you put helium in it. So what happened to your helium balloon after a few days after the birthday party? They get smaller and smaller, and then it starts sinking. Okay, so why is that?
Honestly, never thought of it.
Okay, so do you do your physics and chemistry lesson about the Brownian motion, named after Professor Brown? So Brownian motion is basically, the particles, when you look at in an enclosed environment, they just keep bouncing off in a random motion or random walk. And what happened is the rubber balloon itself has a lot of pores when you actually look at a micro level. When you start having these Brownian motions, they start diffusing out, even with helium, right? So that's why your helium balloon sank. I was very disappointed when I saw it sank when I was young. So that actually I understood the physics afterwards. So therefore, people have come up with amazing concepts of, coating the balloon and so make it longer. And then now there's like aluminum balloons. So actually they last even longer. It can last for like 2 or 3 weeks. So, your Valentine's balloon or, your Christmas balloon can actually stay up much longer. But the concept of using a high molecular weight gas is actually to make it go through these pores a lot slower, because the pores on the shell are somewhat fixed, each one that you created. But then if you make it a high molecular weight, then you can see like it's harder to get through that hole. So it will last longer in the body. So the longer the bubble lasts, the better. When we started way back when, like we have to use an infusion. So it was very like difficult because we were using Optizon. We actually had to keep like having a micro pump, and we have to have this thing prepared with the syringe, and we have the micro tube that actually keep infusing it over the next 1 to 2 minutes before you can actually get all your images. That's how we used to do stress echo as well. So we have to have like 2 pumps going. One is dobutamine, the other one is infusing your contrast. So suffice it to say, that's not great because it's a lot of work. So then we have other different products that's been developed. The next 2 that are still on the market is Sonovil, which is a sulfur hexafluoride phospholipid on the outside, and then Definity, which is the one that we're using most of the time as well. It's a lipid encapsulated bubble, and inside is a perfluoropropane. I wish I know how to pronounce these properly. So the reason why Definity gotten like really a huge market and favored by a lot of people, we've been using it for now last 10 plus years since it's come out in the market, and it's because they have a artificial lipid shell. So there's no issues of prion or human, transmitted disease potentially. So you can explain to your patient this is actually a lab-generated lipid shell or fat shell, if you want to say it, and so it doesn't have any infective potential like the cow's milk or human albumin. And the gas is actually a noble gas which is inert and is being expired by your lung afterwards. And the shell is actually being metabolized by the liver, right? So that's how, like, I heard the explanation yesterday when I was reading echo in the lab, and really struggling explaining this to the patient. We do have a script for the sonographer as well, Neil with us, and we can use this verbal script and, line by line tell the patient to get the verbal consent. We haven't gone to written consent yet, but, this is lab by lab policies. Okay, so again, let's go back to the physics. So again, we typically in adult, we insonate with 2 megahertz, and then this is the fundamental frequency coming back. And there's a smaller tissue frequency that is at 2F, which is like 4 megahertz coming back on the tissue side. On the contrast side, it's the same, and you get actually a lot bigger signal as you just heard because of the acoustic impedance and auto reflection. So again, if you learn anything, this is the graph that you should know about in your day-to-day imaging, because that's what's happening in the background and in what you do. Both the tissue harmonics, which is actually the tissue harmonics imaging that you do, as well as the contrast harmonic, which is looking at these lines. So it ends up with the contrast harmonics, you end up having enhanced contrast effect relative to the tissue signal, so it's a lot brighter, and it's very useful for many applications. I'll just highlight a few that we use regularly, including LV opacification for endocardial border delineation or detection, and it's very useful for 2D imaging, 3D imaging on a day-to-day basis. It's very helpful in stress echo. Is helpful in identifying myocardial vessels and also myocardial perfusion as well. I just want to show you some really old pictures. These are actually digitized from tapes. These are some of the very early work that we did in 2000. So I apologize that you can't see very well, but there are actually contrast effects. So you can see way back when we started off like with contrast, but still, the contrast is not as great as today. I promise I'll show you much better pictures. This is, again, enhancing endocardial border detection. There's actually apical hypertrophic cardiomyopathy in this case. So again, even in the very early days, when we start using contrast, we can see the contrast effect much better. This is actually a picture of a stress echo, and you can see even the very early day, we have the attenuation issue with too much contrast in the beginning. So again, you have to wait until the contrast is dissipated or destroyed at the apex before you can see the whole thing. So these are some of the very early works in year 2000. So at least you can see what it used to look like. So, and then our colleague now back in Canada, Dr. Sharon Mulvey, published a very early paper in 1996, and she's now in Nova Scotia and returning from Mayo. And she published some of the very early animal study looking at visualization of the canine septal vessels using harmonic imaging, and that was the agent way back when. It's called imaging. And Dr. Mulvey now is our CSE president, is one of our world-renowned contrast expert as well. So we're very happy to have her in Canada. And also we can actually use it to visualize coronary arteries. One of the early application of using contrast is by directly injecting contrast using the catheter into the first septal for doing septal ablation. So I was involved in some of these very early works in US when I was young, and we would actually mix up the contrast and inject it directly into the coronary arteries to know the extent of the infarction, intended infarction you're going to create for the septal ablation, so as to say. Okay, there's some other work that was very important in the 2000, which is actually by Dr. Tom Porter, if I remember correctly, is from Nebraska. And again, this is a situation where you have a decrease in contrast effect when you have a heart attack, because there's no tissue perfusion in that area. So these are some of the early works. And this is actually also very famous in the year of 2000. These are some animal studies that look at what we call the contrast curve, and used to be called Way curve because it's named after Dr. Kevin Way, who was in the same lab with Dr. Leon Poy, and looking at the contrast effect and the timing, and using these curves, you can predict the contrast perfusion. The reason why we're still not using it at this point is the challenge of there's certain areas that actually looks great. So especially the apex area and the mid-level, the problem is the base, because the physics cannot get the ultrasound all the way down to the base. So it's still very challenging in terms of doing it on a day-to-day basis, in terms of quantification of perfusion. So that was like a quick review of some of the very basic concepts of echo contrast or ultrasound-enhanced agent. And just now I'm going to show you some of the cases. So this is a 51-year-old South Asian female with chest discomfort on and off, with very positive family history. These are cases that I've encountered at St. Michael's Hospital. So parasternal long axis is not bad. Apical views are not that great. So people have often asked, like, when do you use contrast? So the simple answer to that is when you have two segments that is in the heart that is not well visualized, and that will be an indication as per ASE recommendation to use echo contrast. So similarly, you can see there are more than two segments that we cannot see well. And we really sort of very fortunate over the years having our sonographers all trained in putting in IVs. So that was one of the major limitations way back when we started contrast in history, because then you have to wait for someone to start an IV, and then you have to review the case with the reader before you give contrast. So there was a lot of barriers before we use it. And over the years, what we have done is we empowered our sonographers, so they would actually make the call, they would start the IV, and they would give the contrast. So, that's now makes it so much easier. And now this model has now propagated into the community lab as well, so that we have really good imaging and not necessarily having to involve the physicians or the echo readers to in the decision. So then it makes the use actually much more common. So what should we do in this case? So way back when, we would consider doing a myocardial perfusion imaging, doing stress echo, perform stress echo with IV echo contrast. So we would do the stress echo with chest discomfort with contrast. Just want to show you that different ways of doing stress echo. In our lab, we have both the supine bike and treadmill. So just take a little bit of a detour about the difference between them. So supine bike is really great because for echo contrast and also to some extent with perfusion imaging, if you're interested in that modality, because the patient is always supine and you can capture the image continuously with this patient, and you can also image at peak stress as the patient is exercising. On the treadmill, they keep going and going, and then they get to typically about 100% of the maximum predicted heart rate, and we try to image between 85 to 100, and typically that's about 35 seconds to about 1 minute. So in 35 seconds to about 1 minute, you have to be able to capture all the 5 views. So it actually is quite a high level of echo kung fu, in which many of our colleagues over the years have acquired and improved. And the more you do it, the better that you get. So so the treadmill has this advantage of you can get the meds, for example and also using the typical Bruce protocol, you can actually find out their meds and also indirectly get the VO2 max, etc., etc. And also much more physiological when people are actually walking upright. The challenge is actually acquiring that image because you could obtain the image actually submaximally. This is a major problem when we also have a sports clinic here. Okay, do you know why?
Takes up more space with the treadmill.
Yeah, well, paradoxically, the fitter the person it is, the recovery time of the heart rate is much faster. So now your 60 seconds or 45 seconds now become 25 seconds. So now you have to be able to do all that in 25 seconds. So sometimes what happens is that you'll see we paradoxically actually send the fittest people to actually do the bike instead of the treadmill because of that reason. The supine bike is also fantastic for patients who have back pain because now they're exercising with back. The limitation with the bike is also not everybody bikes. For the longest time in North America, nobody bikes. It's only until very recently, in the last 10 years or so, biking become more popular. So when you don't have the quadriceps, people tend to be easily submaximal because the thigh just gave out or the quadricep just gave up. So these are plus and minuses that you have to consider when you're selecting the exercise modality. Obviously, we like people to exercise if they can. Dobutamine can be an option, although then dobutamine can also have its own challenges because it's not that physiological. But on the other hand, between the exercise modality, we actually have 2 choices. When you refer your patients to us for exercise stress echo, please specify which one. And if you don't specify, we actually default it to the treadmill. Okay, so there's a colleague here who commented the challenge is actually tilting the bike, and it is challenging to bike on the sideways. And this is actually one of the very original pictures I took when we just got the bike, the supine bike, and I had Dr. Robinson, who was our former colleague, to actually be my model. And back then, obviously the technology at the time was so good that we can actually image it through close. But now we actually can't do that anymore. Okay, so moving along. So, as you know, we actually have excellent images. In fact, in our lab right now, we typically use about, let's say 75, 80, 85%? Almost 100%. Yeah? Okay, good. So, there are labs in the country who actually use contrast at 100%, including our colleagues in Alberta. Because one of their challenges in their particular lab is they are the only game in the province, actually, not even in town. So people have to travel quite far away to come in to do the stress echo. So, they have to get the information because it's hard to send them back and come back for nuclear, for example, or some other modality. So, some labs actually use it at 100% when we talk to them. I think over the years, we have gradually increased this number. There'll be another lecture that we talk about stress echo. We can obtain images at base, and intermediate, and peak as well. So you can see that clearly the pictures are so much better than the former pictures that you saw before contrast. Okay, so there are some data to support this use. This particular paper was in 2002. You can see that this has been around for a long time, and you can see the score index. The higher the number is better in this particular study, and you can see the imaging ability to image with the contrast actually better than non-contrast, and the diagnostic yield is much higher. Similarly, this is a study that was actually done among bariatric patients, because at some point, when we try to help our patients who are going through the evaluation for bariatric surgery, often they need some kind of stress testing prior to that. And even with the population, with the bariatric population, actual contrast also perform very well. In this case, the image quality, one is the best. So you can see with the contrast, there are much smaller numbers because the image is better, and the yellow one is on contrast, which is higher number. And the diagnostic yield is actually much higher, and we saved a lot of patients from having other tests such as angiogram, CT angiogram, etc. These are some very old numbers from 2008 to 2012. I don't have the latest one. Back then, we were using a lot of DEFINITY as well, but not as much as we do now. There was actually a quarter at the time. So I thought I'd just bring it back for historical reason. It was 2012. 11 years ago, I still have that slide. Okay, so another case. So 71-year-old male, chest pain for 24 hours, presented to emergency and department. So here you can see the parasternal long axis view is not bad. Okay, the ventricle is not that great. And there's a UFO. And not even flying, just an object at the apex. Yes, thank you, Josh. So even with, tissue harmonic imaging actually looks pretty good. But with contrast is even better. So I think, on a day-to-day basis, we encounter a lot of unidentified object in the heart. So contrast actually helps to enhance. These are very clear examples how this could help. You can see clearly there's a well-delineated clot at the apex in this case. And sometimes we do have, other situations. So now we have an 80-year-old female, history of myocardial infarction, sitting in outpatient clinic for the first time. Again, parasternal is actually not bad. There's something that's over there, right here. Okay, again, right around here. So sometimes it's hard to know for sure what it is, and here you can see there's actually a cutoff sign. So what you just saw was a much more well delineated, thrombus, and this is more sessile thrombus. And you typically see a sharp cutoff line that we see. So the idea of a ventricle is like a bullet. It should be fairly tip-shaped in the apex. But when you see a flat line, either laterally or horizontally or this way, so then you have to start making a suspicion of having sessile thrombus or laminated thrombus. So that's another picture of it, and clearly there's a lack of echo contrast in this area. Okay, so I think that was that case. So this is another one actually. Let's go back, more cases. So 80-year-old lady presented with 3-day history of chest discomfort and came to emergency department. Okay, so let's see. Let's see clearly something wrong. So let's identify all the identifiable chambers. So left atrium, mitral valve, left ventricle, aortic valve, aorta, right ventricular outflow tract, pericardial fat, etc. But what is actually unusual is this particular area. And you can see that the posterior wall is actually thinned out, and this also looks like there's a even thinner portion here at the base. So this is the short axis again. There's a left ventricle, and there's a thing outside the heart. So what are we thinking?
Fusion.
Yeah, pericardial effusion.
Yes,
Yeah. So it could be a pleural effusion. This person actually has some kind of things going on, which this could be a pleural effusion, right, on this side. But what you just saw is a pericardial effusion, pleural effusion, or something really bad. Yeah, thank you, Josh. You're doing very well, Josh. Okay, so here, there's a gap here somehow, right? So this is like a reverse picture. Left ventricle, mitral valve, left atrium, and there's a kind of a gap. So again, this is the LV, LA, mitral valve, right ventricle and right atrium is on this side, and there's clearly a gap, which is not good, right? And the mouth is pretty wide. So you put color, there's color across it. Right? So here you actually PW this area, which let me see here, okay? You can get 2 and 4 flow across this hole. So just to make it more interesting, because it's a contrast top, you can see in the left ventricle here, mitral valve here, left atrium here, there's a gap. That's contrast clearly actually communicated freely into this particular sac that it shouldn't be there. So I think this is a most typical of a ventricular aneurysm or ventricular rupture that lead to a aneurysm that is outside. Then you can have a discussion about whether it's true or pseudo, etc., etc. In this case, the mouth is pretty wide. So what do you think? Really, that definition is like how many layers that is you can get. So if it's a true aneurysm, it will be basically all the layers will be there. With a pseudo aneurysm, then there's only the pericardium that is actually surrounding and make sure the ventricle is actually going. If that's made, it's not a good thing. So the contrast actually helps. So again, here you can see a freely open communication at the ventricular wall. So that's an example of a contrast enhanced study. So the next one is 55-year-old male presented to outpatient clinic with an abnormal ECG. Okay, diagnosis?
HCM.
Yeah. So the apical HCM typically has a very, nice ECG. So we often like stick our ECG on top of our chart before we see the patient, and then we just look at the ECG. And then you have like certain expectation of history and physical and echo findings to go with that. So because of the deeply inverted T-wave, this is the very classical description. I think the original paper was actually written in Japan. Yep. Oh, sorry. Let me see this. Okay, there. So this particular study just now you saw is a space-shaped heart, and with echo contrast, you can actually see better in terms of where things are and where things are not. So here you can see a diastolic space shape. This is actually typically how we defined apical hypertrophic cardiomyopathy, and that goes with the original picture. So that's contrast used in cardiomyopathy. So this is another case, patient of mine that I follow for a long time. So 58-year-old lady was originally from Trinidad. She presented with progressive shortness of breath and chest pain for about 3 months. And she was at a small claims court. And then she started developing episodes of syncope. And just for those of you who are new to downtown Toronto, we're surrounded by many interesting different organizations, including the town hall right next to us is actually a small claims court. So for those of you who watch reruns of shows, they are like, the night court, and it's actually just down the street. So for those of you who are interested in listening into very interesting discussion during your break, you can actually walk in there because it's open. So you can actually see how people plead for their parking tickets or small claims, etc., etc. So I've done it a time or two, and it was actually very interesting. I was trying to fight for my parking ticket or something. But it was actually very interesting to see the interaction. So it's just actually down the street. So she was there. That's why she came to our emergency, because she passed out in that course in the old town hall where the park is, right? And and then she was having like anxiety, nausea, and palpitation. There was no witnessed seizure activity. And the EMS performed a rhythm strip which showed frequent PVCs. She came to emergency downstairs, and the physical exam was remarkable. Past medical history was unremarkable. She was on bisoprolol. She got dizziness and diltiazem. And upon arrival, she developed chest discomfort. And this chest discomfort actually radiated down to her left arms, etc., etc. And then we admitted her, telemetry. What else did we do? So we also did a MIPI scan on her because we thought she was presenting with unstable angina. And because there was a question of like previous infarction in a PMIPI that was done in the community, okay, about a month ago. So with all that information, we decided to do a coronary angiogram. So she started on this typical treatment that we would do. She continued to have chest pain. And this diagnostic procedure is this big. So the coronaries are pretty normal. Okay, nothing too exciting. Okay, I'll let you look at this for a moment. Okay, so this contrast left ventriculogram. So for colleagues from the sonography world, this is a catheter that we put in a retrograde fashion from the femoral aorta. We would come all the way up and actually pass the aortic valve and put the catheter into the ventricle. And we fondly call this catheter a pigtail. Looks like a pigtail in a cartoon. And then at the end of the pigtail, there are a number of small holes, so that when contrast is given, it's like dispersed rather than giving one shot into the myocardium. That's why it's called a pigtail. So here, what do you see in this left ventriculogram? Yeah. I want you to focus on here. Now this is the interesting part. So look at it one more time. So there's a LV outpouching, and also there's a lot of trabeculation in that area. Okay, so this was actually done on Friday afternoon. I think Dr. Leon Poy was there. Dr. Chisholm did this angiogram and said, it's Friday afternoon, but we need to do an echo. So there you go. So the subsequent picture was actually done over here. And just remember, this was actually done quite a while ago. Just to give you the context of how good the image were, even back then. Thank you, Josh, for your comments. So here, you can see, there's something that doesn't make sense, right? So you have, like, on this side is the septum, right? This is the apex, this is the lateral wall, and you can see there are contrasts going up there, okay? So, diagnosis? With the LV gram and also now with the echo contrast.
LV non-contraction.
Yep. So, what is the classic description of LV non-compaction on echo or MRI?
There's a ratio they use of compaction to non-compaction, and then based on that ratio, you can diagnose. That's good. I can't recall the exact ratio.
So the classic morphological description is actually the deep crevices that goes into your compacted myocardium, or what should be the compacted myocardium, as well as what is called fjords. Do you know what a fjord is? Anyone do North Europe, cruises? So fjord is a very common geographical phenomenon in Northern Europe. Typically, it's associated with Norway. Basically, they are all deep crevices into the tall mountains, and then you've got water in here. It was actually created by the glaciers. As they recede, it actually carved into these very deep crevices into the thing. So this is actually what has been described as the fjords as well. So these are additional pictures on the transthoracic echo. Is really confusing. Like you can see that there's a dropout here, but you can't see it very well. And here now, this is the MRI, just to confirm the substantial amount of focal non-compaction involving mostly the apical to mid-lateral wall. So we have made a diagnosis in her, which is ventricular non-compaction. It is a rare type of cardiomyopathy. At the time, it was actually as yet unidentified or unclassified, and had been not widely recognized until very recently, when we start having the access to contrast as well as cardiac MRI. So again, have you learned this in your embryology? Okay, now let's get back to your embryology from way back when. Okay, so the heart actually forms, as early as 2 to 4 weeks, but it's really not formed until 8 weeks into your gestation, right? So by 6 weeks, the heart is actually all abundant fine trabeculae that is present. So a lot of trabeculation in our hearts. By 12 weeks, these trabeculation or trabeculae start to solidify, especially starting at the basal area, and then continue contributing to the added thickness of the compact layer. So this is a process known as the compaction of the myocardium. So the trabeculae that you still see in the heart is the remaining, process that you see from the compaction of the heart. But obviously, there are few patients in the world that actually this process is not entirely complete, either in the whole heart or very focally in part of the heart. And it's caused by arrest of the normal process of endomyocardial morphogenesis during embryonic development. And this is another picture to show the degree of non-compaction. You can see in this case, these are the non-compaction area. So just to give you a brief review of various use of echo contrast. So again, in review, we can use it for 2D and 3D echo. Especially in our case, we do a lot of cardio-oncology, where estimation of the ejection fraction is very important from one session to another. So over the years, we worked really hard. Dr. Leonpo and I will recall that we spent years to convince our oncology colleagues that we can actually use contrast or use echo with or without contrast, rather than subjecting to our patients who go through breast cancer or post breast cancer chemotherapy, because they used to go to Margaret every 3 to 4 months as a follow up. So I think this is one of our success in battle, that we can now use echo to follow up most of these patients for their ejection fraction and get them through the course of their treatment, especially Herceptin in this case. So that's a big thing that we use contrast for, and detecting wall motion abnormalities is very useful. Detecting unidentified objects inside the heart or masses is very useful. And then perfusion is another direction that can continue its development. And stress echo is a big player now, et cetera, and diagnosing certain types of cardiomyopathy is very useful as well. There are a few directions that contrast echo can continue, including like targeted bubbles, and there's also another concept out there called sonification. So because when you use ultrasound to break the bubbles, it can actually enable you to deliver certain materials such as VEGF, so on and so forth. These are some of the areas of ongoing development in the echo contrast work. There are safety issues which we can discuss in our discussion section. There are practical issues. There's introducing of the IV. I think we're by and large solved that problems, but it's still in the community that is still a challenge of making sure all our sonographers are certified or trained with IV. And I think we work very hard on that. Logistics, for example, like if you are doing a portable, like you're really far, and then like you still have to agitate your contrast. So how do you get your contrast? So do you bring enough, or do you bring your agitating machines, or you use another type, which is a one use, which is like Sonoview? So those are options that you have to decide in your own local lab situation. And funding and reimbursement and And fortunately, we actually do have a reimbursement now. So at the time, there was no reimbursement, so it limited the dissemination. In Ontario, the ability or availability of contrast becomes a very important part of the accreditation process as well.